Ah, spring is here. You can finally spend some time outdoors. The grass is green again, trees are blooming, birds are chirping. And what is that? Is it snowing? No, it's way too warm. It's the pollen in the air. First it's the trees, then the grass begins. Well, at least it's better than being stuck indoors and hiding from the coronavirus. You just get your bike tuned up when a mighty sneeze bursts forth. It has to be allergies. You don't get them every year, but the sneezing and runny nose and a little itchiness in the eyes, that's gotta mean allergy season has returned. Well, unless it's COVID-19, but it's definitely allergies. Unless it's not, you're fine, right? Welcome back to the Ogden Surgical-Medical Society podcast. We're really happy that you're continuing to listen with us. I'm Clark Madsen. I'm a family physician and sports medicine physician at McCady Hospital, and I will be one of your hosts today along with Dr. Campbell. How are you doing today, Dr. Campbell?
I'm very well, thank you, Clark. So I am Brian Campbell. I too am part of the Ogden Surgical Society board and family physician in Ogden, Utah, and a part of the family medicine residency, as Dr. Madsen is as well. And we're looking forward to chatting with Dr. Doug Anderson.
Today we get the pleasure of working with one of our other board members, Dr. Doug Anderson. Just as a way of introduction, Dr. Anderson is a Utah native born here in Salt Lake City and went to medical school at the University of Utah. Afterwards, he did his residency and surgical internship at the Indiana University School of Medicine, and subsequently has returned here where he has, amongst his other accomplishments, being a longtime board member with our Ogden Surgical-Medical Society. So we're really happy to introduce Dr. Anderson, have him here today, because we're going to talk about something that's extremely timely. Not quite the COVID-19 this time. We're talking about something that happens to us every single year. We're going to be talking about season allergies.
Oh, thank you so much. It's great to be with you both, Clark and Brian. I'm pleased to be with you. You know, I think this is a great topic too, because it's interesting. Despite all the concern about COVID, you know, allergies right now are really a big thing. A lot of the patients who are still coming into the office are those that have allergy symptoms. So I think it's a perfect time to discuss allergies.
Speaking of allergies, how about yourself? Do you get seasonal allergies yourself?
I do. I actually have seasonal allergies and have some allergies to some grasses and weeds and a few trees, and have had some testing. But I'm not too bothered by it. I would say mine are mild, and so I can control it with avoidance and over-the-counter medicines. But if I go running or jogging in the morning and there's lots of wind out, I definitely have allergy symptoms for a few hours.
Yeah, me too. I'm noticing that there's a lot of fluff in the air, and the aspen trees near my house were definitely giving me some watery eyes and a runny nose.
Well, I'm grateful for modern technology because I've been a happy participant in allergy desensitization treatment for many years and am very grateful for it.
Well, let's start something off here. We'll start off with an easy question for you. A lot of our listeners are used to seeing and treating seasonal allergies, but just to kind of keep us all on the same page, what are some of the most common symptoms that help you know that you're dealing with seasonal allergies versus something else?
Yeah, so that's great. So there's a mnemonic that we use called SLEDO, but basically, sneezing is very common, lacrimation or watery eyes, itchiness, drainage from the nose, runny nose, and then obstruction or congestion in the nose. Those are probably the most common allergic symptoms that we see.
Did you call it SLEDO?
SLEDO. So it's like Slido, SLIDO.
I've never heard that acronym.
Yeah, so it's sort of an acronym that just helps us remember the different symptoms that are common in allergies. But those are really common.
Wow.
Well, with many allergy treatments now available over the counter, what do you suggest to the casual patient who isn't severely affected, like yourself, for example, what would you suggest that they start with before they come see either their primary doctor or their allergy specialist?
That's great. So I think, again, one important um, thing a patient can do is preventative. So, if you know you're allergic to lawn, and you're going to be mowing the lawn, and every time you mow the lawn, you're going to maybe want to wear a mask, or be careful about rubbing your eyes after you've cut grass. Um, and so number one, avoidance. Number two, there's a lot of really good over-the-counter medicines that are helpful. There's cetirizine or Zyrtec, is a common allergy medicine. It's the one side effect is that it can cause sedation. There's fexofenadine, which is another allergy medicine that is approved for pilots. That's not supposed to cause significant tiredness, and so they can use it. And then there's others. There's loratadine or desloratadine, and certainly a common one that's used is Benadryl, but there's lots of side effects with that. And then there's lots of over-the-counter sprays now. There's fluticasone sprays, which is a sort of a steroid spray that can be used, and a lot of different variants of that type of a nasal spray. And then there's even now some antihistamine-containing sprays along with the steroid that are helpful too. Certainly, some patients are going to also want to use some Sudafed, which is a decongestant. Another spray that's available too is cromolyn, which sort of stabilizes cells in your body that are responsible for releasing the histamine that can cause the runny nose and itchy eyes and sneezing. And so that's a cromolyn spray. And that's another one that's often used. But those are sort of the common over-the-counter medications that are used. Some prescription medications too, but those are the main ones.
That's quite a few of them. Is there an order in which you usually prescribe those?
So I definitely try to steer away from those that have side effects. All of them can cause drying symptoms, but you certainly want to try to avoid those that are sedating if you can, especially if you need to take them during the day. And so I would certainly avoid the ones that have, if you look on the information, the ones that are associated with sedation. And then, like I say, fexofenadine is one that does not cause sedation, or loratadine or desloratadine are not supposed to cause sedation either. And then the nasal steroid sprays, I think those are a great one to use anytime. They can be associated with nosebleeds, so you have to be careful with those. So all medicines have side effects, but those would probably be the ones I would start with first.
I ran into an interesting situation recently where I was involved in some training for our audio-visual technology that we are using a great deal at the present time. And in the course of that, had the opportunity to do some observation. And I saw a young mother with a very young infant, only a couple of months old. And she was talking to the provider on this shadowing experience I had about whether or not allergies could present this early. What do you tell patients as far as when can allergies develop in their young?
In general, most small children, it's rare. So like 1% of children have allergies. So a small number of young children have allergies. Really, we don't see a lot of children with inhalant allergies, meaning they get from outside, such as trees, weeds, those kind of things. Those are rare in kids until they get to be about 3 to 4 years of age. However, having said that, perennial allergies can present in very young children, such as peanuts, animal dander, dust mites, molds. And so in kids that are having early on, for example, they get a rash if they touch peanuts or peanut butter, certainly we recommend testing in those situations if done appropriately.
Now, are we talking like 6 months and younger, or usually kind of when they're older than 1 or 2, 3, age 3?
Yeah, so that's a great question. So I've seen them. So again, for age 3 and above, we will check for grasses, trees, weeds, animal dander. But for young kids, let's say they're a year old or even a little bit younger than that, if there's a history of watery runny nose or getting rashes if they touch certain things, milk or eggs or peanuts, we'll definitely test for them. But usually they're more like 8 to 12 months of age that we'll test. And we've surprisingly, in those kids that have a positive history clinically, a fair number of them have allergies. especially if there's a family history. If both the parents have allergies, there's like a 75% chance that the child is going to be prone to develop allergies. Or if just one has allergies, there's like a 25 to 50% chance that their child will develop allergies. So it can definitely be that they have a genetic predisposition to having allergies.
You mentioned peanuts. When I was young and in training, the concept was avoid peanuts until you make it to college. And clearly that has changed recently. What are your thoughts about introducing peanuts and other nut-like foods at a much earlier age?
Yes, so that's a great question. So there's a study called the LEAP study where they looked into that. And they actually found that in kids that were introduced small but regular doses of peanuts, they were less likely to develop severe allergies to peanuts as they got older. And now that doesn't mean they won't develop allergies, and they have to be watched. But now even some places are doing a little bit of desensitization using a little bit of a small amount of peanut paste in young children to help reduce the incidence of severe peanut allergy reactions. That is a sort of a little bit of a hot topic because we all know that certain people are prone to very life-threatening reactions to peanuts, and so it has to be done with caution and with lots of observation. And certain kids who may be on that desensitization with a small, steady dose of peanut paste or amount of peanuts per day, 1 peanut per day or whatever it may be, if they ever stop taking it for a period and then are reintroduced to it, they could have a severe reaction. So it's something that people who are started on have to be very vigilant. But you're right, things have totally changed as far as the shift on thinking about peanuts and whether we should introduce our kids to peanuts or not. So some say that now we're saying early introduction, small amounts are actually protective in a lot of cases.
Well, that brings us to one of the main questions we had for you. A lot of our listeners are primary care providers, and treating seasonal allergies is something they do all the time. That being said, there's got to be a level at which it's appropriate to refer to a specialist such as yourself. When do you think that level is? What should we try first, and when should we say, you know what, let's get a specialist to help us out with this?
I think that's a great question, Clark. And so the answer would be the same one that we use. Not every patient that comes into us has started on allergy immunotherapy or shots or drops or whatever it may be. It depends on their symptoms. If they, so a lot of people that have bad enough allergies that it's affecting their quality of life. There's a significant number of people out there that miss work or are missing school, or their productivity at school, or their productivity at work or concentration at school is decreased, whether it be from allergies or from the medications they're given to treat their allergies. And so if they get to the point where, number one, their symptoms are not adequately controlled, and they're always with the runny nose, always rubbing their nose or scratching their eyes, and they're having secondary problems or comorbidities associated with their allergies, such as ear infections, or their asthma's getting worse, or they're having sinus infections, then maybe they probably ought to be thinking about being seen. These are patients that have already tried over-the-counter medicines, and it doesn't seem to be adequately controlling. So that's when I would say they ought to be referred.
Very good. Hey, let's take a little bit of a break from the topic. I want to get back in and talk about these treatment options for allergies. Before that, we've been asking all of our guests about their experiences lately with the COVID-19 pandemic. How is that affecting you, and what are you doing with your isolation?
As far as my personal life, it's affected my personal life quite a bit. My wife and I love to go out to dinner. We love to go to movies. We love to go to sporting events. And so that's all stopped. And so as far as us personally, we spend a lot more time together. Obviously, we're not social isolating with each other, but we are going on walks together where we can get outside. We are spending more time talking and reading together. We don't go to church. We participate in our church ceremonies at home. In family, we used to always get together. For my larger extended family, we used to get together once a month. And so last night we had a Zoom family get together. I still do some church meetings through Zoom technologies. As far as my practice, a lot of people are staying home. They're following the governor's advice, and unless they're really sick, they're trying to stay home. We have done telemedicine. Technology specialists in our office have hooked up the computer so that we can, through Doxy.me is software that we use, but we've used that to do telemedicine with the patients. When I've on call, I've still had to go into the ER, and we just use extra protection and gloves and gowns and sometimes special masks called PAPRs or N95s to help protect us from a patient who may be that's of interest, there's concern that they could be infected. So we're just very cautious, and obviously we've stopped doing any elective surgery for the time being and only do those that are more urgent. So it's had a big impact on our practice, but we've adjusted and there's pluses and minuses of everything you do, I believe.
So you haven't quite figured out how to do an endoscopy via telemedicine yet, huh?
So that we haven't, but we have bought, Clark, we have bought a couple special little devices that we could eventually take out to some of the clinics, that it's like a tiny little pencil device, and the provider or whoever, or even a patient could put it in their ear, and it's a little camera, and it could download to their phone, and we could see that, or put it in their mouth. So we do have a couple little devices we bought just in case we needed. But for endoscopy, we try not to do it. But if we do endoscopy, we've taken precautions to help decrease the risk for us, again, through personal protective gear. And then also we have the patients do sort of nasal lavages with a dilute betadine solution that's supposed to be protective against the virus. So it's been interesting times for sure.
Pencil camera is incredible.
I think that's amazing. I'm hoping that they are not swallowing the betadine or bleach as they try to.
We hope so too. We tell them not to, but anyway, hopefully not.
So a question as we move on, and thank you for sharing how that's affected your practice and your family and your life at home as well. I'm sure that's relevant to all of us, and it's fun to see how technology has let us at least continue to provide care as much as possible. I'm curious, Dr. Anderson, as you know, we've had both allergists and ear, nose, and throat physicians speak to us at the Ogden Surgical-Medical Society meetings over the years. I wonder if you could share how you actually do a workup for a patient with possible allergies and how that might differ if the same patient was seen by an allergist.
First of all, I would hope that we could always work together, and I would say a lot of the principles for allergy are the same in both professions. And I know there's some competitiveness between the two groups, but in reality, both specialties have done allergy for many years. In fact, the beginnings of allergy for the otolaryngologists began in 1922 and 1921 when a doctor by the name of French Hansel worked beneath a doctor at the Mayo Clinic, and he was a fellow under this man. Of them were due to allergies. And so he subsequently developed a significant interest in that, and he went to work after his fellowship at Washington University in St. Louis and developed an allergy clinic. And all of the ear, nose, and throat physicians had to do a rotation in that allergy clinic because he felt like it was so important that an ear, nose, and throat physician understood how allergies affected the health of patients who were coming into the ear, nose, and throat clinic and how they were treated. So they wanted them to see what the picture was of a patient who had allergies and then how to treat it adequately. So, and in fact, in 1941, this is back when it was eyes, ears, nose, and throat, there was the American Society of Ophthalmologic and Otolaryngic Allergy was started. And it's interesting, that was a few years before the Quad AI came into existence. So they both have their roots many, many years ago, back into the 40s. And then in 1981, the ophthalmologists separated from the ear guys, and then it became the American Academy of Otolaryngic Allergy. And so that was back in 1981. So we've been doing allergies for many years. That's been a staple part of our residency program and treatment. And so we've been doing that for years. But a lot of those principles are really the same. And as far as workup, how we do it, we I'm sure we do it the same way, but basically we do, as far as if we were going to do a diagnosis, our diagnosis, besides taking a clinical history, we would do testing that is similar to what they do with the allergists, in that we do a sort of a multi-prick test, and then based on that, we will do a dilutional test. And that's maybe where it separates us a little bit from the allergists. A lot of allergists, once they diagnose an allergy, will go out, they'll do a 1 to 100,000 dilution or weaker, and they treat all allergens the same. And the issue with that is that as they progress to a stronger and stronger dilution, to get to a maintenance level that they would keep the patient on as far as immunotherapy, that may take several months, maybe even up to a year. Whereas our academy, and again, I'm not saying one is better than the other. I think both methods have pluses and minuses, but we will try to find what's called an endpoint, which is the weakest dilution that'll cause a progressive wheal or swelling in the skin. So it increases by at least 3 millimeters, the set point above what the control is, the negative control, and then it will progress to bigger and bigger wheals, and so we call that the endpoint. And wherever the endpoint is, we feel like if you dilute just a little bit more than that, you can start there at a safer level, and so that you don't have to dilute as much as the general allergists do, and so it gets you, if you start at a stronger, more concentrated solution, you can get to your maintenance level quicker. And I know there's pluses and minuses on both sides, and that's just how we were trained. And that's sort of the little bit of the theory that's behind it. But instead of 1 to 100,000, it would be 1 to 62,500 dilution, or even stronger, more concentrated, depending on where their endpoint was. So that's the difference. We do a multi-prick. We find out if they're allergic to something, and then based on the wheal size, we'll either dilute it back more or go even a little more concentrated, depending on where their endpoint is.
Well, that was an excellent review, and thanks for the historical perspective as well. That's very enlightening.
Yeah.
I think I agree. That was really an interesting look at it. We oftentimes are asked to counsel patients. They'll ask us questions about how effective desensitization treatments are, or should I go see the allergist, or should I get testing? Let's start with the desensitization. How effective is that? Are most people able to desensitize, and is it dependent on what the allergen is?
So that's a great question. The answer to that is the studies have showed that in the majority of people, it is effective. And I can't say that effective 100% of the time. We have a certain percent, 10 to 20% or more, that maybe just, it seems like it helps, but maybe not, or they can't tell, and so they don't. But there is a significant, for most patients, improvement in their allergy symptoms. And that's something I've seen with my own experience, but in the literature, that's definitely been proven that through the normal subcutaneous immunotherapy, there is definitely improvement that results not just symptomatic, but also in the levels of circulating antibodies that are there, the IgE antibodies, and some of the other cells. And so there's evidence that there's changes in the immune system that are consistent with a patient's improvement in their symptoms.
When a patient does respond to the immunotherapy and they've reached their maintenance therapy, how long do you recommend that they continue to have their injections?
Typically, patients will do, depending on the method they use, but they will ramp up depending on how severe their allergies are. If they're not as severe, it doesn't take as long to reach a maintenance level. But if they're severe, it may take up to 6 months to where they start at a very dilute level and they're exposed, weekly to a little bit stronger concentration of the allergen or the antigen that causes their symptoms. And then they'll reach what's called a maintenance dose. And that's somewhere between 6 months and a year, or maybe even after a few weeks, depending on the method that they're using or depending on the strength of their allergies. And then they will stay on that maintenance dose anywhere from 6 to 12 months. And then, depending on how they do, maybe even for a couple of years, but then there will be a gradual weaning off, so to speak, where they're treated instead of every week or every 3 to 4 days, they may be treated, every 2 weeks. They'll come in for injection. And that is just based on the person's symptoms. So let's say it's been a year on maintenance therapy, and they come in and they decide they want to try every 2 weeks. If their symptoms come right back, then we continue on that maintenance level every week. But eventually, they'll be able to wean down to every 2 weeks, and then maybe every 6 to 12 months, they'll wean a little bit further to maybe every 3 weeks, and to some people, every 4 weeks. But in general, we say it's about 3 to 5 years.
And once they have completed that 3 to 5 years process and have stopped the injections, do you see that maintaining their allergies at that lower level for the rest of their life? Or is there a cycle where after a period of time they again are on shots for a 3 to 5 year period?
The hope is that those changes that occur are more long lasting. Certainly, there are patients that I've seen in my practice where they've said they did well for a while, but their symptoms are coming back. And those patients will retest them. Sometimes we'll find something new they weren't aware they were allergic to. But in general, I think our hope is that those changes are more permanent. But it could be with time, some of their symptoms sort of come back. But the whole goal is to get them off of their medications that they're on. In my experience, most people have prolonged benefit.
Excellent.
Wonderful. Unfortunately, our time is starting to come to a close. I had one more really important question I wanted to ask you, and then we'll close up with a last question. What in the field of ENT or allergy, what's got you really excited right now? Is there something you see coming on the horizon that may change the way we practice medicine? Anything that gets you excited?
I think eventually there'll be better treatment for food allergies, which is a big cause for anaphylaxis, as you know, and so it's not as perfect as the skin as the inhalant allergy treatment, but I think we're getting more molecular understanding of that, and that's going to be better in the future. So I'm excited about that. Number one. Number two, I think there's increased use of biologics, and I know you guys have heard of that, but they're basically antibodies that have been produced against certain areas of the immune system to sort of disrupt or block some of the allergic responses or asthmatic responses. And so I'm excited about that. For us, it's a great option to treat asthma currently, and also nasal polyps, and then also urticaria. Those are sort of the main areas those biologics are being used. But it's interesting that a lot of those patients, their allergy symptoms will improve significantly. So I think that's sort of an exciting up and coming thing. They're quite expensive right now, so it's not something that you can prescribe for everyone. But those are some new things on the horizon that attack both the antibodies involved in allergies or asthma, or their receptor sites, or the interleukins that are part of that whole cascade of inflammation in allergies and asthma. That's exciting, I think.
I think that'll be really exciting and interesting when we're starting to treat asthma patients. We'll give them their albuterol and their biologic. That'll definitely be a game changer.
Yes.
So my final question for both you and Brian, just finish off. We're kind of stuck in this COVID world we're living in. It doesn't look like it's going to disappear anytime soon. One of the ways I'm coping with it is I'm catching up on some books that I haven't read yet. So I'm going to make my book recommendation for our listeners. And if either of you have a book or TV show or some form of entertainment you want to recommend, here's your chance. But the book I want to recommend is one that I've heard some good reviews about. I haven't read it yet, but I've listened to the author speak about it, and I'm really excited to read it. It's called Range. It's by David Epstein. He's the same author who wrote The Sports Gene. And it's an interesting book where he talks about the benefits of either being a specialist or a generalist, and not just in medicine. I think most of it is just in general life. And so I'm kind of curious to see what different stories he has to say about that. How about you, Brian? Any books or anything you're interested in sharing?
Well, I'm motivated at this curious time to look back at humanity's response to previous medical pandemic challenges. And there is a marvelous book called The Black Death by Hatcher. And it's a study of an English village, Walsham, that encountered the bubonic plague in 1348. And it's how they responded. And it's a wonderful insight into the challenges. The mortality of that pandemic far exceeds what we're seeing with COVID-19. In the pandemic that struck medieval Europe in 1347 to 1351, the average death rate was 50%. It's very enlightening and very sobering. And yet we're all humans, and many of our responses then are similar to some of our responses now. So it's been very interesting reading.
How about you, Doug? Any recommendations?
Yeah, so I just finished. It's sort of a long book, but I just finished Alexander Hamilton. I sort of like history too, and I thought that was great. I really enjoyed that, especially there's a lot of bickering going on back then like there is now. I mean, they hated each other, our early government leaders back then. And so it's interesting how they were able to accomplish great things, but it wasn't always easy for them. So I thought it was really interesting, and I like that quite a bit. I like history though, but I think there's a lot of great books out there, and so I've read that one. And another one that I really liked is it's called Keys of the Kingdom, and it's an awesome book, and it's sort of a different book, but it's about one person's that makes a difference, even though he's way out of the mainstream of things, but he makes a huge difference in how he takes care of basically the poor, and he maybe doesn't get the worldly recognition, but he makes a difference. And so I thought it was an awesome book. So if you ever want a good read, it takes a little bit. It's a little bit longer book, but it's a great book. It's called Keys of the Kingdom.
Well, those are all good book choices. I'm going to have to look into those. I do want to put a plug out there. If any of our listeners have a recommendation for us to plug on here, or questions or comments for Dr. Anderson, please go to the Ogden Surgical website and leave us a message. We're working on making it easier for you to leave us messages, and you can leave us a voice message, and there's a chance in our future episodes you'll get your voice placed on podcast, and we'll try to respond to your thoughts and questions. I just want to finish up and say we're really glad to have you here today. It's been fun interviewing you, and we look forward to possibly getting you back to talk about some other subjects here in the future. We want to finish up. I'm going to turn it over to you to let our providers know how to send patients to you. What's the best way to get patients to you?
Thank you. Thanks, Clark. So I'm at the Ogden Clinic, and they can call our number directly, which is 801-475-3072, or it's douglas.anderson@ogdenclinic.com. douglas.anderson@ogdenclinic.com. But you could just call. So just at the Ogden Clinic, if you call the main operator, I'm sure they'll connect you. But we're happy to help you out. Or if you have questions, I'm happy to talk to you about it.
Well, Doug, Brian, thanks for spending some time with me. I hope you guys have a good afternoon.
Great. Thanks so much, Clark. Appreciate it. Thanks, Brian.
Bye-bye.
Bye. Thank you.
This podcast is produced by the Board of the Ogden Surgical-Medical Society. The executive producers are Clark Madsen and Teresa Puskedra. Our sound design and editing is Colton Gomez. Today's hosts were myself, Dr. Clark Madsen, and Dr. Brian Campbell. We're very appreciative to the members of the Ogden Surgical-Medical Society for their contributions allowing us to produce this podcast. And we hope you'll return for our next one. Thank you.